This morning, my name is Jeff DeBelko. I have the good fortune to direct our Environmental Change and Security Program, and on behalf of our colleagues of the Africa Program, its director, former Congressman Howard Wolpe, who as usual is in either Burundi or DRC at the moment, it's our great pleasure to co-sponsor this discussion today of From Relief to Development, Gender-Based Violence Interventions in Conflict and Post-Conflict Contexts. An important issue, certainly one that's unfortunate that we have to spend so much time and attention on, but one that we really must. Seeing a few new faces, just allow me to say that you're sitting here at the Woodrow Wilson Center, which is actually the formal memorial to Woodrow Wilson. So instead of building a monument on the mall that we could go visit as tourists, or at least we go there when people from out of town come, because not that we ever get out to do that ourselves, right? Instead of doing that, they set up a living memorial reflecting Wilson's legacy as both a scholar and a politician. He was our only president to have a PhD. So this is, quote unquote, a living memorial where these worlds can come together and hopefully learn from one another and improve each other's endeavors. The Environmental Change and Security Program, we are a 14-year-old program that tries to bring together communities in the area of health and population and development, environment, and in even the foreign policy and the security policy context. So obviously, as we're talking about conflict and post-conflict environments, those are different communities that don't often talk with one another, but really do. And I think today, one of our particular missions, and why I think this is going to be a very rich discussion, is that we're really focusing on this relief to development continuum. One, again, even while both communities working on gender-based violence, often not having as many opportunities to talk, and different time frames, different tools, different mechanisms. So it's terrific that we can be part of that discussion, one that I know is going on, but one that I know and trust will be even deeper and a richer conversation, in part due to the efforts of our collaborators and our sponsors in many ways today. USAID's Office of Population and Reproductive Health, Michal Avni and Deanna Prieto have been tremendous partners in working with Gib Clark and my colleagues here at the Wilson Center, as that Office of Population and Reproductive Health has supported many of the programs here at the center. So it's terrific that we're able to yet again collaborate with them, and today's meeting is possible with their help and assistance. So let me turn very briefly, hopefully you picked up the bio statements and the participants list out front, so I'll just introduce our panel very quickly so as to leave more time for the discussion. Ian Askew is going to kick us off. Ian is a senior associate with the Population Council, Pop Council, based in their Nairobi office, so it's terrific to have him here in town today. He's the director of Pop Council's Frontiers in Reproductive Health Program, a USAID-funded program, Operations, Research, and Reproductive Health. So Ian's going to kick us off. Heidi Lehmann is the Senior Gender-Based Violence Technical Advisor with the International Rescue Committee, and 10 years, more than 10 years, experience in the field of gender-based violence, lots of different parts of the world. Lots of training, lots of implementation, lots of really practical advice and experience on how these programs and interventions work. And then Meg Greene, who's been a longtime friend of the center and someone we've had here on a number of occasions, is going to be our discussant. Meg, as you know, is the Director of Population and Social Transitions at the International Center for Research on Women. And I think most importantly and proudly from our Wilson Center perspective, the author of a brand new policy brief that we call Focus, published here at the center, that's entitled Poor Health, Poor Women, How Reproductive Health Affects Poverty, which really digests and makes accessible, I think, to a wider audience some really rich and extensive research she and Tom Merrick from the bank have done on this issue. So we thank her for joining us today, and we urge you to pick up her papers. Just one word on procedure. When we go through, after we've had the presentations, we'll have a Q&A. We're actually webcasting the event live. So for those of you on the web, you can see the PowerPoints and download them from the computer and follow them along. It'd be much easier than trying to see behind our speakers. And then furthermore, when we come to the Q&A, we'll have colleagues bring you a microphone if you could use the microphone to pose your question. So Ian, please, the floor is yours. And Heidi, if you want to come out to the side.
Good morning, everybody.
Please see the screen.
Excuse me. For my presentation, I'm going to focus on looking at what we've been learning recently about addressing sexual and gender-based violence in stable populations, in amongst the general population. And I'm doing this because the natural fact is that it's quite a rapidly changing field at the moment, and so I wanted to review some of the lessons we're learning and what's going on at the moment, and to try to sort of stimulate a discussion about how that can also be influenced by and influence and interact with what's happening in emergency and humanitarian settings. So first, let's just remind ourselves that in the general population, sexual and gender-based violence is pretty prevalent in most African countries. This slide shows data from 3 African countries from DHS data, and it's remarkable how similar it is across the countries. Approximately half of the women report ever experiencing sexual or physical violence. These are ever married women, and about a quarter in the last year. So it's fairly similar across countries from East, Southern, and West Africa. So today, what sort of responses are we seeing in Africa and beyond? Primarily, there have been responses in 2 areas to this issue. One in terms of prevention, and the other in the area of criminal justice procedures. In terms of prevention, there's a range of activities are happening, but I guess I'm trying to sort of summarize things here, and you can probably summarize them in 3 broad areas. In most countries, you'll find civil society advocacy groups working to try to raise the profile of this problem in the country. And these are more or less active depending on the countries. But they in recent years, there's a series of networks establishing themselves in various countries and between countries, trying to put across the message to their government, to other actors in society about how important the issue is. You'll also find a range of community-based programs, primarily implemented by NGOs. And some of you may have heard of some of the more well-known ones, like Raising Voices, Stepping Stones, and approaches like this that seek to generate behavior and attitudinal changes at the community level. So there's quite a few of these activities have been going on. And again, there are some regional networks establishing themselves to try to share lessons and understand better what's happening. And then more recently, in some countries, we're beginning to see governments becoming much more involved and much more engaged. In at least 2 or 3 countries, you'll see government-sponsored media campaigns, advertising and providing education about this. And in several countries, there's now a move towards mainstreaming not just gender issues specifically, but issues around gender-based violence within some of their ministries. So in terms of the areas of prevention, these are some of the activities that we're seeing happening in the region. From the angle of criminal justice, we're seeing this is an area which has been established for quite a while. Most countries have laws and have legal procedures, either formal or traditional, for prosecuting and criminalizing physical, sexual and other forms of gender-based violence. And these vary greatly between countries. In many situations, they're inherited from the previous colonial authorities, and so what you'll find in Anglophone and Francophone and Lusophone countries tend to depend on the colonial power. But there has been a move recently in the last decade or so for countries to take another look at those laws and try to update them and make them more relevant to the current situation. Most countries have some certain procedures and protocols for collecting evidence, forensic evidence, and processing it through the system. And these, again, we're finding a lot of countries now revisiting these because, again, they tend to be based on outdated forms and formula and procedures that don't always reflect what's going on or collect the data in a way which doesn't easily lend itself to enabling prosecutions to be followed through. And then the third area to note here is the types of justice delivered in such cases. And these can vary. Inevitably, the major type of justice given out is in terms of criminal sentences for jail sentences. But in some countries, these are beginning to be questioned as whether they're the right approach, and other procedures are being used. In those countries which use side by side a traditional justice system, then there are other forms of justice being used. And this is a tension in several countries, and I can speak particularly from my experience in Kenya, where we have a tension between the Islamic courts and the civil courts, and they each have their own approach to dealing with gender-based violence. And this is a discussion going on in those countries where there are traditional justice systems in place. What I want to focus on primarily, though, is the issue around the health sector's engagement in addressing sexual and gender-based violence. Because of these three broad areas of prevention, criminal justice and health, it's the health sector that's lagged the furthest behind until most recently. But there are some exciting and interesting developments going on now, which I wanted to sort of raise and we can perhaps discuss more fully as a group. There are at least two main reasons why the health sector needs to be more fully engaged. The first one, as you'll see on this slide, is the tremendous number of health consequences and the range of health consequences that can come out of gender-based violence, ranging from fatalities through, well, I don't need to go through them, but you can see them here. There's a wide range. And I'm putting them up here because quite often, and certainly at the country level, I think a lot of people underestimate the range of health consequences that there are. Obviously, depending on the type of violence and the severity and for how often and so on. But it's quite often underplayed. I think in many African countries, gender-based violence is not seen so much as having health consequences. It's seen more of a social partner and power issue in general populations. And so there's a need at the moment to try to get more education, give people more information about the wide range of health consequences that can be associated with gender-based violence. And then the second main reason is that the health sector itself is very well placed to be able to respond for a number of reasons. As you saw, excuse me, in the first slide, if between half of the women that generally come to the health facilities have experienced any type of violence and a quarter have experienced it in the last 12 months, then this is clearly the health personnel are interacting with these women on a regular basis and have the chance to either identify women at risk or who are currently being abused. Secondly, we have to bear in mind that given that previous slide, the mandate of the health sector is there to try to address the majority of those health consequences. All of those consequences are within the mandate of the health sector. So there is there already a large responsibility for the health sector to get more engaged in addressing that range of consequences. The other reason related to this is that most of the skills required for that do exist in the health system somewhere. The problem is at the moment they tend to be dispersed throughout the system, physically, geographically, by cadre of worker. And so one of the challenges is to try to bring together the appropriate packages of skills and the infrastructure required for addressing this. And then fourthly, we shouldn't forget that in most communities, health staff can be quite influential, and they can play an important role in advocating against violence, in being engaged in preventive activities. So there are a number of areas where the health sector can work more thoroughly, and I've just put them together in this diagram to try to put a visual display of the sort of areas, and I'll just quickly go through some of these. There are probably some others, but these are, I mean, as a way of trying to organize thoughts, most of the areas that are currently being explored seem to fall into these five main areas. In terms of behavior change and prevention messaging and so on, there are at least 4 areas where the health sector can and is beginning to get more engaged. What we are seeing is that where there are community-based structures and NGOs available and that are already themselves dealing with these issues, then bringing health personnel in to give the messages both about the health consequences and about the availability of medical services to treat and support them is a good entry point to trying to raise the profile of the issue in the communities, and as well as making people aware of what services are available. And this can be done excuse me, either, as you see here with through the first bullet, through existing structures like community health committees, like chiefs, barazas, and other groups and so on, or with NGOs working in the communities. But it can also be done through orienting and training community-based health workers that are already in the system. Virtually every health program in Africa, in fact most countries, thank you, have community-based health workers of some sort or another. And there's an interesting challenge there as to how they could become more engaged. Then within the clinics and in the interactions with with the clients they see, there are at least two areas here which can be and I guess should be more actively explored. The first is that most clinics around the world generally have a group health education session first thing in the morning. Usually this will last anything from 10 minutes to half an hour, and it can be on a range of topics. And so if this is one opportunity to try to bring the issues of gender-based violence into the clinic environment. And then the other is the issue of during individual consultations, during a woman's consultation, raising the issue and providing education. But that brings us to the second area, which is quite a contentious issue, and this is whether or not health sectors, the health system, should become involved in routine screening or routine inquiry into experience with or suffering consequences of physical and sexual violence amongst its clients. In principle, it's a real missed opportunity, and this is why, as you know, probably in the States and other countries with strong health systems, it's now becoming a routine procedure. There's a routine part of the consultation. It's one of the questions or series of questions that are asked. But there is still a lot of concern about whether this is feasible and and ethical in weaker health systems. And the trouble is, at the moment, there hasn't been any real attempts to try this out at any scale. And it's an area I think that we do need to look at and carry out some basic pilot testing to see what's feasible, how safely can it be done. Because we do have to worry about the whether or not a woman's safety can be guaranteed if she discloses this information, whether it's ethical to raise and ask about these experiences if the system then cannot respond to it, can't provide any treatment for her, and whether the providers' attitudes enable them to be supportive and without taking on and trying to victimize the woman. So this is an area which I think is something which we do need to address much more thoroughly in countries with weak health systems, because it's proved feasible and effective in strong systems. So is there something we should be doing, at least on a pilot basis, in weaker health systems? The major area, I guess, where you would focus on the attention of what the health sector can do is in treatment and support at health facilities. This diagram briefly summarizes the types of treatment and support that can be made available. The box in the middle there that's what's pretty much being available at most places at the moment. Injury treatment for physical abuse and for sexual abuse, clinical assessment to determine what other issues are there, and the collection of forensic evidence for prosecution. The other four boxes are beginning to emerge. There's some experience with these areas, but particularly with an increasing interest in addressing the issues of sexual violence and the realization of the interaction between certainly sexual violence and STIs, HIV, exposure to pregnancy and so on. These other services are providing emergency contraception, prophylaxis for STIs, PEP and counselling and testing for HIV, and trauma counselling. These are areas which some countries are beginning to experiment with and to work out how best to provide these services, how feasible they are, whether they can be integrated into a broad model of treatment and support. But it's, again, we're just at the beginning of this and just seeing where these can go. But being built around that core group of treating injuries and doing assessments and collecting evidence. But one thing we do have to bear in mind is who does present for sexual assault services. We know a lot of people that are assaulted do not report either to the police or to the health facilities. But our data show here that we've collected from Zambia, we have similar data from Kenya, similar data from South Africa, show a number of interesting things. First of all, if you look at the numbers here, these data were collected over a 4-year period in a district in Zambia, and you'll see that the numbers here, 1,800 police records, 1,000 hospital records. So the people presenting here are more likely to present to the police first rather than the hospital. And so this is an important thing to bear in mind when we're thinking about providing services for survivors. And secondly, take a good look at the age distribution. 60% are children, at least, and the majority of those are 10 and under. So the services here need to be able to respond to the fact that those who are presenting, this may not reflect obviously what's going on in the general population, but those coming for services, either legal services or health services, are very young. These are children, and consequently the services do need to be set up that way. We've also found from our data that the children are more likely than the adults to report knowing the perpetrator. And this is a difference in terms of, for example, data we have from South Africa showed that 80% of the children knew the perpetrator compared with 30% of the adult women. So there's a big difference here. You're dealing with a clientele that knows who did this to them. But having said that, only a small proportion, and this is adults and children, mentioned that this is within the extended family. This is someone who's related to them. So we have to bear these things in mind when configuring the services, either at the police or at the hospitals. So my question here for the audience and for the field as a whole is how can we best organize services, and especially services for sexual assaults? Because at the moment most African countries have no dedicated medico-legal services, and those that do have some services, they tend to be organized poorly, organized separately, and it's very hard for a person to get the full range of services that are needed. There are some emerging approaches which are beginning to be documented, but we need far more documentation to learn what's going on. And there's a list of them here. The first one is the approach of trying to integrate everything into one center. The medical aspects, the legal aspects, the psychosocial aspects. And one of the best known examples of this is from South Africa, the Tutuzela care centers. And this model is currently inspiring a number of countries. I think Zambia, Uganda certainly are places I'm aware of where this model is being rolled out. And clearly it has a lot of advantages that everything can be provided in a survivor-friendly setting. But at the same time, obviously being a single center, it can only be available to a relatively small number of people. And we've yet to see any evidence about the cost effectiveness of this approach compared with other approaches that are maybe more decentralized. So some of the other approaches that are being looked at, the second one is an area that ourselves, we're working with quite a few partners here on this, is looking at trying to integrate and provide a more comprehensive package of health services based around the district health, the district hospital, or that level of facility. And there's examples here across South Africa, Ethiopia, Zambia, and Kenya that we're working on. Another approach which is being tried by one of our partners in South Africa is to have a help desk at a clinic. So if a woman comes to the emergency department reporting rape, then there's a desk, literally a person sitting at a desk who can provide legal aid, can get them linked up with the police, can help them to find trauma counselling and so on. So this is a sort of another model to look at and to consider. That isn't sort of the full-blown integrated model, but it brings it together there. A fourth area which we're exploring, particularly in Zambia, is looking at trying to strengthen the police response. Some countries, certainly Zambia and South Africa, now have either what they call victim support units or victim empowerment programs. So they have set up programs to work with survivors of violence. But these are very few and far between, and so far a lot of it has been on the legal aspect, on trying to help them to get legal justice and prosecution. What we've been doing in Zambia is try to get the police more engaged in some of the health aspects. So we've been giving them some basic training in counselling, and also getting them to be trained as providers of emergency contraception. And so just trying to get them become stronger first points of contact, and offering not just the legal service. And then, I guess, sort of more overarching and the general goal here is to try to establish bi-directional linkages between the police and the health facilities. The vast majority of people that are going to report an experience of violence, be it physical or sexual, will report to police or health. And so the trick here is to try to set up linkages between the two, and how can that best be structured given the setting for each country. So if the challenge is out there, how best to organize an improved and strengthened response, what are some of the issues to be looking at? This is obviously by no means a comprehensive list, but it's some of the key issues that in our work we're finding across the board. These are the sorts of questions that every group interested in trying to organise a more integrated, more comprehensive response should be looking at and asking. I'll go through them very quickly, but they should be fairly self-explanatory. The first one, what types of services are appropriate for the survivors presenting? As I mentioned earlier, the evidence seems to suggest that those presenting at the moment are primarily children, primarily girls. But we do have situations where there are young boys presenting, we have adult women, we have adult men presenting. And as the services become more widely known, then that demographic may well change to reflect the situation in the general population. So we have to think about what type of services are appropriate for this clientele, for these people coming to the health and to the police, and organising them accordingly. Secondly, one of the real challenges is to consider this concept of first point of contact. Where someone goes is very, very important, and the type of care they receive is critical to determining what will happen to them from then onwards, whether they have an awful experience and just run away, whether they have a good experience and want to follow through, both from a health and a legal and a counselling perspective. So the types and the quality of the care at the first point of contact is critical. And it's something we do need to understand more fully, and to work with governments and others to work out what should be the standard of care and what range of services should be available at that first point of contact. Which then leads to the third point there. If you're not able to provide every service, as you would in the Tutela model, then how can you set up referrals for the other services? So if someone comes to a police station, they open a case, and within 72 hours they have to go to get their medical treatments, how can you set up a referral so they get to the nearest available spot for those services? Then, if you're looking at the hospitals, how best to integrate the medical services within the hospitals. The work we've been doing shows that in most hospitals, all the services are there somewhere. But both in Kenya and in South Africa, we were finding that on average, a woman coming to report sexual assault saw 12 providers, 12 different people, and she would have to basically find her way around the hospital to go for all these different services. So an obvious thing is just to try to bring all these services into one spot, one place, and ideally just one or two providers. And we've been successful in one hospital in South Africa in setting it up that way, where we've now reduced the number of contacts down to an average about 4 rather than 12. And the time consequently reduces as well. But it's a major challenge. But the good news is the services are there. The bad news, the challenge is how to bring them all into one package so that there's a smooth flow between them. The fifth point there is the one I raised earlier. What is the capacity of the health system to offer screening routinely? If it's something we think we should be trying to do, what capacity is needed, and how best to get that? What training is needed? What investments are needed to get that level of capacity that we feel comfortable offering a quality and ethically sound service? Number 6 is an interesting one, which really came through when we made a visit to Uganda to find out what's going on there. In Uganda, it's an absolute requirement that anyone presenting for a rape must then open a case in the police. There's no ifs or buts, you have to do it. And this is proving to be a real block, because a lot of people don't want to open a case, they just want the treatment. But it's showing itself to be a block to treatment, that women are not going for treatment, and or providers are not providing them the treatment because of the whole expectation that as soon as it's written down as sexual assault, it has to be reported and a case has to be opened. Other countries are taking a more lenient view on that, but it's an issue to be discussed in each country's situation, obviously. But it's something to bear in mind, because it does have a considerable bearing on how services are organised. The seventh point there, role of forensic evidence. This is, again, proving to be difficult, both in terms of what type of evidence is acceptable and convincing and plays a role in proceeding a case through, but also how is that evidence collected, how is it preserved, how is it processed from the hospital or the clinic or the police station through to the central courts where the case is heard. And a couple of countries are experimenting with what they're calling rape kits, where basically it's a cardboard box about this big that has inside it all the necessary supplies needed to collect the evidence, and you then put the box, seal the box, and it goes off that way. That's one approach. But it's a major problem with the quality of forensic evidence, it getting lost along the way or disappearing mysteriously along the way. That happens very frequently, and it's a big issue that needs a lot more attention. And we're working with our partners Liverpool VCT in Kenya to try to strengthen this chain of evidence from where the point of collection through to prosecution. And then finally, the major challenge, I guess, underlying all of this is that, as you can tell, this is clearly a multi-sectoral response. It involves the health sector, it can involve social services, it can involve the Justice Department, Home Affairs. It can, depending on the structure within a country, then you're looking here at many sectors, and how to organize cooperation across these sectors is a massive challenge, because any government trying to have a multi-sectoral response to an issue, it's a challenge, and that applies whether it's the US or an African country. And it's something which we're struggling with, to trying to work out how that can be done in each country. So we are just at the beginning. Some of the issues here that are sort of important. I think we do have to acknowledge there has been a rapid increase in awareness of the importance and the extent of sexual and gender-based violence in the general populations. We are now realizing that it is a problem, a substantial problem, and governments are taking it on board as being something they do need to address. Increasing number of countries are passing laws around this, which gives legitimacy to the efforts and provides a basis for funding allocations, for setting up structures and so on. And particularly in East and Southern Africa, the clear links with HIV is adding both an extra urgency, but also it's opening up funding opportunities for providing services, given the high level of funding going to HIV in that part of the world. However, there's still a huge lack of experience with providing these services in a development context, which is hampering a lot of the response efforts. And as I just mentioned, the multi-sectoral approach tends to often mean that it falls between the cracks. One sector will assume another one's looking after it. So when you start talking to people in the health field, they'll say, but that's the police's responsibility. And you talk to the police and they say, yeah, we're doing it, we're fine, we don't need to link up with the health people. What are you talking about? So it's something which needs to be sort of a bringing together of the sectors if this is going to work. And how that can happen in each country is a major challenge. Just a couple of slides to end with. What I've put here, which is probably a bit difficult to read, but I've got some handouts for you that will be interested. We've got a program of research going on at the moment, which is jointly supported by PEPFAR and by Sweden and Norway. And what we're trying to do here is work with a series of partners in East and Southern and West Africa too, trying to look at what would a comprehensive response look like. What are the key issues to be considered in these three broad areas of community-level prevention, medical management, and the criminal justice system? And some of those bullets there give you an indication of the sorts of issues that we're looking at across the board. So our starting point is to work with an organization, and in most cases with the Ministry of Health or the police, or in some cases NGOs, and then to help them to think through what would it take to expand what they're currently doing to work with these other groups, to be able to address these other issues and link up either direct linkages, referrals, or organizing things amongst themselves. So this is our network. These are the countries we're working in. And at the moment, we're focusing on pilot efforts to try to sort of demonstrate and document what's feasible, what sort of effects they have in the immediate term. But we are realizing as we're going through that we need a lot more operations research around determining effectiveness, and particularly the cost effectiveness across those different types of models that I mentioned. Because quite often one approach may make a lot of sense or be very attractive, but people tend to then not focus on the alternatives. So either there will be a lot of focus on community-based approaches, or on these one-stop centres, or on the strengthening the legal systems and so on. So a lot of our work is just trying to get a better understanding of what's feasible, use that both for advocacy at the national and international levels, to try to get an understanding that this does take a multi-sectoral response if it's going to work, and we're going to improve the quality of care for women and males. suffering from sexual and gender-based violence in this region. So, thank you.
Thank you very much, Ian. We'll turn to Heidi next, go through the presentations, and then we'll have a chance for Q&A. And I think we'll hear, in some ways, from Heidi how some of the challenges that Ian has pointed out would be ones that she'd love to have, given some of the difficult settings that IRC is working in.
All right. Good morning, everybody.
Good morning.
As Jeff said, my name's Heidi Lehmann. I'm the Senior Technical Advisor for Gender-Based Violence Programming for the International Rescue Committee. And I am delighted to have the opportunity to start looking at this continuum from relief to development, GBV interventions in conflict and post-conflict settings. And IRC is active in programming around the world, and we certainly know the range of conflicts that we're seeing around the world and the different contexts that each of these different countries present, from Afghanistan to Ethiopia to Nepal to Sudan. And I want to say a couple things about emergencies, because that's what I'm here to talk about. How do you do GBV programming in an emergency? I'd like to frame it in terms of looking at an emergency. When we're talking about an emergency, we're talking about a situation. I'm talking about conflict-related emergencies. A situation where there is insecurity, a situation where there is violence, and a situation where there is damage to the infrastructure, where systems that had previously been operating are either seriously compromised or outrightly destroyed. Okay? I'm talking about situations where we see massive movements of people, either internally displaced within a country or across borders. I'm talking about situations where massive amounts of people come together in makeshift shelter, oftentimes, most of the time, overcrowded, not a lot of access to water, food, so on and so forth. I'm talking about a situation that overwhelmingly impacts women and children, regardless of where it happens. So that's just to frame it a little bit. So when we talk about GBV and emergencies, I think it's also important to remember that gender-based violence is not one thing, all right? It is an umbrella term that encompasses a range of abuses. And under that umbrella, you have different categories: sexual violence, economic violence, physical violence. And under any one of those categories, you're going to see 4 or more different types of violence. So when we talk about GBV, we're talking about something very, very big. In emergency situations, the focus is typically on sexual violence, even more specifically, conflict-related rape. Historically, from Kosovo to Liberia to Sudan, Nepal, sexual violence has been a part of that conflict. Over the last, it's relatively recent though, that we've really started to talk about it, and even more recently, that we have started to actually respond. 1995, we see that UNHCR came out with the Sexual Violence Against Refugees. In 1999, the Reproductive Health for Refugees Consortium came out with their guide to reproductive health in refugee settings, in which sexual violence was a chapter in that. And more recently, we have the Interagency Standing Committee guidelines, as you can see, for GBV interventions in humanitarian settings. Again, you see, you can't really see it, it's tiny, but focusing on prevention of and response to sexual violence in emergencies, all right? And I think it's important to note, reproductive health advocates have really been historically the voice that has pushed this issue in emergency settings. Okay, and typically, right, when we're trying to address sexual violence in conflict, The humanitarian community's response has focused on response, all right? More specifically, it's focused on service delivery. And that takes it back to, I think, in part, the fact that reproductive health advocates are the ones that have really pushed this. So you see that the service delivery initially started through health centers, reproductive health programs, so on and so forth. And to date, I would suggest that the focus has still been on health response for survivors and what we call psychosocial support for survivors. All right. Prevention. It's improving, and I hope that we talk about this a little bit in the discussion, but in emergency situations, prevention is often put on the back burner for a number of reasons. One of which is the fact that, sexual violence and conflict is so common that we've started to think about it as being inevitable. So people see it as if, well, what can we do? There's also the issue of people say, well, how, for example, in Sudan, where there's, lots of people continually with guns, how do you do prevention? How do you stop this from happening in the middle of a war zone? Another issue is the fact that there's, this is typically not the top issue on donors' list. When I started doing this work several years ago, on average, IRC was getting between $150,000 to maybe $250,000 to implement a 12-month GBV program. So there is limited funding for this issue. That means that we have to prioritize. And we are always going to prioritize in terms of service delivery that we hope has an immediate impact of saving lives. Okay. Another issue around prevention is that many people and humanitarian aid workers that have been doing this a long time see prevention, a major part of prevention, as changing attitudes, right? I mean, there's a reason why sexual violence continues to be part of a conflict, right? There's a reason why, so many people defend the fact that a woman is raped as part of a war. Why people defend the fact that a man has the right to beat his wife. And part of that is attitudes and beliefs. And folks see that, addressing those attitudes and beliefs is not feasible in an emergency situation. And I've sat at the table many, many times where people say it's not even a priority. So prevention gets put on the back burner for those reasons. I'm going to talk to you a little bit about the International Rescue Committee's approach to gender-based violence in emergencies. And our strategy, our overall strategy guiding our programs globally is called From Service Delivery to Social Change. And this has developed organically over 10 years of programming. And I think this title says a couple things. First of all, it says, in emergency situations, we have got to act, right? And part of that action is making sure that we provide life-saving services, because sexual violence is a life-threatening issue. So we provide life-saving services that mitigate or reduce the consequences that survivors of conflict-related rape face. In addition to that, though, we also recognize that gender-based violence, which overwhelmingly impacts women and girls, is a social problem. Okay? It is a social problem. And because of that, if we are not working towards some sort of social change, right, we are going to forever be responding. So when we talk about IRC's approach to GBV, we're looking at service delivery to social change. And on average, the International Rescue Committee is in a country for 10 years. So we might go in at the onset of an emergency, but we stay for many years after that. Okay? And again, just to frame the problem, and this was, organic. We started our first GBV program in Tanzania in 1996. And about 3 years ago, we stepped back and we said, okay, right, we're addressing this huge and complex issue in an extremely chaotic situation, right? We have to put some structure around it, all right? And out of that came the way that we look at the problem of gender-based violence, whether it's in a conflict situation or a post-conflict situation. And we see it as a huge and complex issue, whether it's in Nepal or Liberia or Washington, D.C. And we see it as a problem that needs to be addressed by understanding how it's related to women's social and economic disadvantage and discrimination. Now, typically when I show this slide, a hand shoots up, and some of you might be putting your hand in your pocket because it wants to shoot up. But folks say, but you know, it doesn't only affect women. What about men? Okay, certainly men can be victims of gender-based violence, no doubt about it. IRC's approach and IRC's programming and the statistics that we see in our programs, I would say 95% of the clientele is women and girls, okay? So in our framework, we look at it as a problem that has to be addressed by women's social and economic disadvantage and discrimination. What does that mean, right? That means to get to the root cause of it, we have to challenge gender equality. That's fun. Places like Afghanistan, Nepal, Liberia. Talking about gender is, yeah. Promoting women's rights, and then creating social, political, and economic environments where women and girls can enjoy those rights. Okay, so what we say is it's not enough to go in and educate about human rights. It's not enough to go in and say, you know, violence against women and girls, there's health consequences, right? We have to go the extra step and support these social and political economic environments where women are safe and secure and can be part of rebuilding nations. All right. So just real quickly, you know, to try to put order around the chaos, we looked at our programs and we deconstructed what our programs were doing, okay? And out of that we said, okay, we could see that our programs were functioning at 3 levels, right? The immediate level was at the community level, right? Where we were in emergencies, we were doing things like providing healthcare services, where we were doing things like getting out into the community and making sure women had the permission of the men to seek healthcare services, right? Oftentimes, simultaneous to that, we would be working at what we call the systemic level, where we were either supporting systems and strategies to monitor and respond when these acts of gender-based violence were happening, or, you know, if these systems were absolutely absent, trying to put some temporary systems in place. And then we would work at the structural level, which often took the guise of preventive action, oftentimes through advocacy for the application of guidelines, international laws, allocation of resources, those types of things. Okay, so what does response and prevention look like in an emergency? Before I tell you, I'm going to take a drink of water, so just ponder that a minute. Thank you, Margaret. Okay, well, let me start by, and this is actually it's not a slide, but I was thinking about this when I was listening to Ian's presentation, and I was thinking, you know, there are so many similarities between what we do, right? But it's oftentimes, you know, we're in fast forward when we're doing it. So in the Central African Republic, we did an assessment to look at the issue of sexual violence against women and girls there. Within 2 weeks, we had trained a core, about 3 or 4 key healthcare staff, on providing treatment to survivors of sexual assault. As Ian said, these healthcare staff have the basic medical training. Oftentimes they have most of the supplies. And it's a matter of putting that together and often working with healthcare workers on their attitudes and beliefs towards survivors. So within 2 weeks, we had set that up. We had set up a very basic referral system, right, between healthcare, the health clinic, and those providing basic counseling, psychosocial support. By June 2007, we were seeing 30 women and girls a day that were coming to us and saying that they had been raped as a result of the conflict. 8 months later, we had provided services to 1,200. Right, so it's similar in that we have to set up healthcare services. We have to set up these psychosocial response services. Extremely basic, but still addressing the issue in such a way that women feel comfortable coming forward. We start to break the silence, and we certainly reduce the health consequences. Another example is IRC's GBV program in Liberia. And when I got to Liberia in 2003, it was literally like a day after Taylor had gone on his merry way to Nigeria. And I remember meeting with UNICEF and saying, there's 9 IDP camps, there's about 1 million IDPs, there's a lot of sexual violence, and we have $25,000. What can you do? And I said, well, before I answer that question, let me just go out and have a look-see and see what's going on. So one of the first places I went to was the Samuel K. Doe Stadium, SKD. Anybody been there? All right, I see some nods, okay. And it was just in the paper, unfortunately. But I went to SKD, and I walked in there, and it was jam-packed with IDPs. And it's a little stadium. It's a small stadium. And we started to talk to some folks there. I was with our Liberian staff, and right off the bat, we identified conflict-related rape, that there were many women in there that had been raped over the last 6 months, over the last year. We then identified that because of the crowded conditions, there was a lot of what we call opportunistic sexual assault going on. We identified the fact that there was a lot of sexual exploitation around food and other things going on. We found that domestic violence, interpersonal violence between husband and wives were a problem. So then, looking at this is where the overwhelming part of it comes in, right? And looking at the resources, we then had to decide which we prioritized. All right. So then just looking at the response, oops, I don't have the response up there. Don't take that to mean that there was no response. There was a very vibrant response. So the response focused on, as I said, we started to work with health workers. Even though the healthcare system was destroyed, there were still the health workers from that system. So identifying those health workers, community-based health workers, starting to get the message out there is the very first step in letting women and girls know that there's a place to go. Second thing is making sure that once they know that, simultaneous to that, we have to be making sure that there is a place they can go. Okay. Then we train what we call, depending on the situation, social workers, helpers. I think you might call them first responders or first point of contact in some situations. These are the folks that know how to validate, support, and advocate in many situations for these women and girls. So the focus in Liberia was very much on response. Prevention, we did a couple things there. We certainly advocated a lot, right? We advocated for the application of international standards, so that you didn't have 40,000 people, living in a place that was not designed for anybody to live in. And we also did We also use safety audits in that stadium, as well as in the 9 camps that were set up throughout Liberia, trying to identify with the women, right, what were the most dangerous areas in the camp, what were making those dangerous areas, and what were their suggestions for making those areas safer. So, overwhelming attention on response, working towards prevention as well. Okay, so 5 years later, we're still there. We're still working on response, but the way that we do it now is very much through supporting the Ministry of Health. So we're working with the government ministries to make sure that their systems, that their policies, that their hospitals are getting to a place where they can address the problem of violence against women. Again, the focus is still on sexual violence, but we're slowly moving towards these other types of violence. The most common type of violence, let me ask you, what do you think is the most common type of violence that IRC's GBV programs see? Domestic violence, right? Overwhelmingly. I mean, you know, about 2 minutes after we get into a country and start to do the sexual violence programming, this problem of domestic violence emerges. And certainly after the conflict ends, you know, we see huge numbers of domestic violence. So we're working with the healthcare system to try and address that. All right, let me run through some of the opportunities, challenges, and lessons learned. You know, the opportunity is that we start to break the silence. You know, this violence against women and girls that happens, it doesn't start with conflict, right? It's not going to end with when peace comes, but what it allows us to do is start breaking the silence that has surrounded the issues. It provides us with an opportunity to start to improve systems, influence systems that are going to protect women from a variety of abuses. There's a few challenges to doing this work. One of them is, as I said, you know, the Liberia example. Programs can be overwhelmed by the scope and scale, and this is not a priority on donors' list, right? We've started to hear about it more in the newspaper. We've started to read editorials about it. You know, the money, we have not put the money where our mouth is yet. When the funding is there, it's typically in 12-month cycles. That's an emergency response. So we go in, we start to break the silence around this, you know, really sensitive issue, and then we say, you know, our funding's done. We'll get back to you. The political will to address what is seen as a sensitive and soft issue is lacking. I don't think that we've clued in enough to the fact that this kills people, right? And when it doesn't kill them, it seriously impairs their quality of life. And I don't think that we've clued into the fact that impact goes beyond the individual. It goes to the family unit. It goes to the community. Another challenge is that humanitarian communities become stuck in this idea of emergency programming, and we get stuck on this focus of service delivery as opposed to work at the systemic and structural level that is going to move us more towards preventing or addressing the root cause of the problem. And we can even see this in other challenges, you know, folks that want to move past that emergency mentality, even the resources and guidelines, the IASC guidelines I talked about are focused on emergency settings. So what have we learned? As I said, GBV does not start when a conflict does, and it's not going to end when a conflict ends. I remember being out in DRC a couple years ago, just after the peace agreement had been signed out there, and I was talking to a group of women, and I said, you know, what do you think about the peace agreement? And they said, well, you know, we're waiting for it to get here. So, you know, just a reminder that this abuse continues well after any signature on a peace agreement. Another big lessons learned is that, communities are more open to discussing sexual violence perpetrated by others that happens as part of a conflict than they are when we start talking about conflict or violence that's done by members of the community. Right? As Ian said, and IRC's statistics will match that, when we talk about some of these different types of violence, oftentimes the perpetrator is known to the survivor. And when you start pushing the envelope there, there's a lot of potential for backlash. A relief to development approach, including work at the community, systemic, and structural level, it's imperative to long-term solutions to the problem, which is why IRC has set up our framework for programming the way it does. And the last thing is that, no matter what the destruction is or the impact of the conflict has been on the infrastructure, that before the conflict, there were systems in place. They might be weak, they might have been limping along, but systems were there. And the IRC has learned to start to work with those systems, and even if they're not functioning, to have a good understanding of what those systems were, because those are the systems that we're going to want to influence after the conflict ends. Thank you.
Thank you very much, Heidi. Meg, why don't we just have your discussing comments, and then we'll have time for Q&A.
I was asked to reflect on these two presentations and offer some suggestions about bridging the relief development gap in GBV programming. I wanted actually first to say thank you to the Woodrow Wilson Center for hosting this event, and to express my respect and appreciation to Ian and Heidi for their presentations and laying out the issues. In a way, I think on the basis of these presentations, the programming gap is something of a straw man, in the sense that I think we can see many, many connections and overlaps between them. So what I thought I would do is just talk about some of the similarities and differences, and then raise just a few points that I thought would get us going in some kind of discussion about the issues. So we've just heard about how programs to address gender-based violence are structured differently in the context of relief or humanitarian assistance and development. And the speakers addressed a whole set of issues that are kind of broad themes, as well as exploring some specific context-specific illustrations. The thing that really strikes me the most about this is the high level of gender-based violence that exists in so-called peaceful times. And that, for me, is just the basis on which we need to think about the commonalities and similarities and think about programming in this area. Gender-based violence exists in a whole range of forms, as Heidi mentioned. She was referring to the term as an umbrella that includes many different kinds of violence, and it exists in contexts where development work is being undertaken. It exists in conflict settings, but perhaps with more of certain expressions of violence emphasized in some settings or others. A correlate of that reality, its prevalence in so-called peaceful times, is the extent to which, whatever the social conditions, there's a way of naturalizing or making gender-based violence invisible in some way. I think we're all familiar with the kind of the way that gender-based violence occurring in the private sphere is therefore seen. It's both actually invisible and also seen as something that one can't kind of intervene easily in. And in conflict settings, what happens, I think, often is that it's, except for the vision of people who are working to address these issues in conflict settings, it's, a small, it can be seen as a small subsidiary, a soft issue, something as somehow less important than the kinds of violence that are occurring as a result of the conflict, which is likely to be structured along different dimensions other than gender. So just a few points for reflection and I hope convergence. First, the big question for me in hearing these presentations today was, can prevention be addressed in every setting, or is this where this kind of work diverges in the two settings? I think there's a clear need for integration across health services, legal systems, community education, and activism. And obviously this will be much more difficult in settings where conflict is current or in the recent past, but it's very important to undertake that prevention effort. Second, I think it's worth thinking a little bit about this, that gender-based violence does not just arise from conflict, it is an essential tool of conflict, the means through which the conflict is carried out by one group against another. And yet, in circumstances of conflict, gender-based violence can often be personalized or individualized in the sense that the response can be focused on
I'm Randa K. Alley from George Mason University. I wanted to ask the first two speakers, Dr. Subiros and Dr. Land, social capital.
Sorry, we have lots of meetings.
If you could comment briefly on how social capital links into identity, and does it compromise the
Mike,
notion
could you get
of
the
assimilation,
audio off, please?
or does it?
Usually we only try to do one meeting in one room at one time.
Immigrants feel more comfortable.
Sorry, Meg.
That's quite all right. I thought maybe
Somebody's
there was really a
channeling in
vociferous disagreement. I didn't think I'd said something that controversial, So again, just the way in which in development settings, gender-based violence can be individualized or naturalized as something that occurs in the context of the couple, and it recedes into the background in circumstances where a broader society-wide violence, not along the dimensions of gender, is taking place. Third, to me, the issue of limited funding calls not just for a focus on service delivery, but really on community mobilization. I think Ian's medical community and justice framework is a very good point of departure for working in conflict settings as well. And I also very much liked the distinction that Heidi was making between structural and systemic. So structural, what are the laws and policies that exist, and systemic, what are the mechanisms through which through which implementation and enforcement are occurring. So I think all of these aspects are needed. And indeed, I think given the weakness of law and order in conflict settings, mobilizing people on their own behalf seems especially constructive. And a couple of examples of this that come to me are the campaign in Nicaragua after Hurricane Mitch, a campaign to counter domestic violence that there were billboards saying, domestic violence, a disaster we can prevent. So not, taking that opportunity to deliver that message. Another, I think, very feasible community mobilization program in South Africa conducted a public education program on gender-based violence that showed, demonstrated as a model communities responding to domestic violence in their midst by going to households where it was obviously taking place and beating pots and pans, and so thereby activating the community to respond to these issues in their own midst. Obviously, very, very effective in creating that kind of peer view of what's going on, and disapproval, community disapproval for what's going on. And the safety audits that Heidi mentioned seemed especially relevant anywhere, both in situations of conflict and in any circumstances. I think I could easily imagine uses of that concept here in Washington, D.C. as well. Next, just reinforcing the centrality of prevention and social change efforts, whether programs are working in conflict or development settings. I wanted to refer to a BASICS report that was written in 2006 on health programming in post-conflict fragile states. One of the messages of the document was that it's not that specific diseases or problems need to be addressed, but that, quote, what is responsible for most morbidity and mortality in many countries can perhaps be better answered by terms like conflict, political instability, poor governance, abject poverty, and so on, than by one or more diseases. If this is so, then the important issue becomes how can health sector programs be designed and implemented in such a way that they contribute to identifying and resolving the political, social, and even economic drivers of fragility within a given country. And for me, the inspiration in that message is that there's an opportunity to use the health system and use other service delivery mechanisms to communicate a message about peace and harmony. And the report that I just mentioned recommends reinforcement of the so-called peace dividend, short-term, high-impact activities that make very visible public contributions to peace and get people thinking about operationalizing peace and cooperation. And it seems to me that a number of prevention efforts around gender-based violence would seem to fit this mold perfectly, and it would be a way of talking about gender-based violence in a broader framework that, as it is, it ends up being segregated as something that is gender-related, as opposed to a broad type of violence that is prevalent everywhere. And finally, I wanted to mention some research that's going on that I think is relevant to this discussion of prevention and treatment, and the concept of gateway attitudes and behaviors. Gloria Ko of USAID and a group of researchers at AED are working on some research to test the concept that changes in certain key attitudes and behaviors can lead to a whole set of improved health and other kinds of behavioral outcomes. Sort of giving as a negative example the way smoking can be a gateway to a set of other unhealthful behaviors. In this research, it's looking at the way more gender equitable attitudes and mutual respect can lead to more communication, more self, care of self, care of partner, perhaps a reduction in drinking, and other harmful behaviors. So that if you do the prevention work around gender inequality and promote the kinds of an alternative vision, both of how men and women can relate to each other, and provide skills for people to operationalize that vision, that you may have a large number of positive effects of doing that work. I think I'll stop there. I look forward to hearing your comments.
Terrific. Thank you very much, Meg. Why don't we do that? Turn to the discussion. You've given us a very good jumping off point with raising the questions that you have. My colleagues have microphones, as I mentioned, because we're webcasting this. We want to make sure that those folks online can hear your questions and know who you are and where you're coming from as well. So who would like to kick us off in terms of posing some questions for discussion? Why don't you go, Liat, right there, and then come down here? Please, go ahead.
Hi, my name is Julie Giat, and I'm a doctoral fellow here at the center. I felt like Heidi was anticipating my question, so here it is. I wanted to know, where are men located in the solutions? And so I ask that because my focus is on the rehabilitation of former child soldiers. And so despite their crimes of mayhem and murder, they're considered traumatized victims of the conflict. And so I want to know, in what ways are young people who are forced to rape in the context of conflict also treated as victims?
Wow, so there's a couple questions there. There's in terms of, men as part of the solution to violence against women and girls as a global epidemic, and then how do we deal with child soldiers that were victims themselves and forced to commit these acts. Well, I think, I'm going to answer. That's a good question. Good questions. Good jumping off point. I think one of the things that we have realized is that, men have to be part of the solution. And in order to make them part of the solution, we have to stop assuming that they're all perpetrators. And even those that have perpetrated violence, we cannot excuse the behavior. We can't overlook the behavior. But we do have to frame it in a social construct and work from there. So, for example, in Liberia, we have men part. It's actually called Men Part of the Solution Project. That's going into its second year. That is based on a behavior change and communication strategy, where we are working with men's groups and helping to facilitate cross-gender dialogues, helping men to identify their own behaviors, and then to deconstruct those behaviors and look for other behaviors instead of violence. So men are obviously central to preventing this problem. I'm going to stop there.
Okay. There's a question down here, Leon.
Thank you very much for your presentations. My name is Ginny Bouvier. I'm at the U.S. Institute of Peace. And I have a lot of questions that emerged from your presentations, but I'll start with just two. The first has to do with faith-based organizations. It's interesting to me that you focused on the legal and the medical sides, and I'm wondering if, in your experience, the faith-based groups have formed part of the prevention strategies or the emergency responses, and to what extent and where you see their interventions fitting into the overall kind of structural, systemic approaches. And the other question I had has to do with the approach of training health workers and the idea, this is extended a little bit from the idea that men are not just perpetrators but may be part of a solution as well, thinking about women not just as victims but also as empowered and potentially trained to translate their victimization into a form of citizenship and advocacy. There's some very interesting projects that I'm familiar with in Colombia, for example, where the women victims are trained to give psychosocial support. They're trained professionally to give psychosocial support to other victims, and that enables them to kind of sustain without the long-term financial implications necessary for trained health workers, professionals to come in, but to really use their experience to then help others who can then help themselves and help others as well. So I'm wondering if you could comment on those two aspects.
With regard to the first one about the role of faith-based organizations, there are some operating, and I guess I sort of lump them in with community-based approaches generally. But I must admit that none jump out. I can't think of a strong example that we've come across. I mean, I'm sure there's some out there, but I think some faith-based organizations in the countries where I work have still yet to work out themselves how they're going to address this, because obviously it's going on within their organizations themselves, within their own churches, wherever. And I think there's a lot of work needs to be done with the leadership, be it Christian or Muslim religions, as to their take on this issue. And it gets back to the point that Heidi was making about putting it in bigger context of gender relations. And the churches themselves are still struggling with that in that sense. So while you see them involved in counselling and support and care in that sense, As I say, I'm struggling to find a good example of them providing leadership and going forward with that, from a church-based perspective. On your second point, yes, I mean, there are a couple of groups we work with do have these victim support groups. The group in Senegal has one, and both groups we work with in South Africa have victim support groups. And these are, but the challenge there is how to create and sustain the groups in a routine sense. It's the sort of thing that NGOs do very well, but if you're trying to strengthen the regular Ministry of Health clinics or something, then you've got to build that in there somehow, and that's where it gets a little trickier, is to make that part of the routine structure, if you like, of what you're trying to do. But yeah, we certainly see them in an NGO context, but it's the challenge is getting it into, and they prove very useful. So I think it would be an important part of the way forward. Yeah.
Okay, Mary Ellen, right there in the blue.
Could I say something?
Oh yeah, please, Meg. And why don't you hand it to Mary Ellen so we're ready? But go ahead.
I wanted to say something about the need to work with men, which is absolutely fundamental. And one, I think, very positive example that occurs is something that can be cultivated in peacetime and has implications for periods of conflict, is work with the military. You have large numbers of young recruits, and they are open. You have this opportunity to work with them on what it means to be a man, leadership, what kind of role they play in the community when they go in, a protective, developing a sense of pride and responsibility about protecting and caring for the communities in which they're deployed, et cetera. So I think, we've heard some negative examples, but there are a number of countries that are doing some very good training around gender equality and generally the prevention of gender-based violence with the military.
Mary Ellen?
Mary Ellen Stanton from USAID. I'd like to thank the panel very much. This is such a important and challenging area, and so I really appreciate this work. I'd like to talk a little bit more about what I actually think may be a facile assumption, that working with the health care providers is a logical entree. Not that we shouldn't, but that it may be a lot harder than we think. I'm profoundly influenced by a report that came out of Kenya, Failure to Deliver, that discussed the violence that goes on in healthcare settings, in maternity care settings, by the healthcare providers themselves. These are the very same people that potentially we're asking to engage in very compassionate and sophisticated work in changing behaviors, in which they are in sittings. If they are not engaged in the violence in this themselves, they're complicit in it. And as somebody has mentioned, they may be in domestic settings where they're victims of violence themselves. I also think that the gender issue gets mixed up or is complicated by issues of difference in tribe, caste, socioeconomic class, and so forth. All people are not viewed as the same or in the same way viewed as that they should be treated well. So it gets very complicated, and so I would just like to hear more about that, because I'm not sure that it translates so easily. And the other thing, which actually is linked to this, is a comment that I think that we need a lot more research. What I hear is about innovative, inherently logical solutions that relate to advocacy and communication. But I think that the database, the evidence on what solutions actually result in behavior change, seems to be a real huge need here.
Anyone want to tackle those?
Well, I'll give it a shot, Ian, and you can have my back. All right. So, Mary Ellen, first, thank you for seeing the logic. I appreciate that. And healthcare is one entry. It's one entry point, and I think as you point out, we have to tread carefully there and not make an assumption that that the healthcare workers' attitudes and beliefs are different, than some of the folks that are perpetrating this violence or being complicit in this violence. And so I think that's the first thing. And and IRC has seen that firsthand. I mean, we have healthcare programs in more than 20 countries. I mean, we support thousands of healthcare workers around the world, and what we have seen consistently is that both benign, benign actions on their part that re-victimize, and then some not so benign attitudes and beliefs that impact survivors in particular. So one of the things that we have developed is it's a training curriculum, but it's on DVD. So what's that called? It's a multimedia. We've developed a multimedia training tool for the clinical management of sexual assault, and so we are going to be using that with all of our healthcare staff. And a major component of that is would fall under the bedside manner, so to speak, the guiding principles of respecting and supporting a survivor, her right, and the right to health care. It's a rights-based approach to health care. So that's one aspect. I think another thing around the health care as the focal entry point that we often overlook, but we're hit in the face with it country after country, is the medico-legal connection, right? Ian mentioned Uganda, but every country I've worked in, whether it's Sierra Leone, Liberia, Congo, Sudan, they all have a legal aspect that's connected to healthcare, and it very often mandates that either a woman that has been sexually assaulted goes to a police doctor, or a woman reporting it automatically opens a case, right? So because of that, we've spent a lot of time developing or supporting other entry points in a community, women's community centers, other structures where women can go to seek services, and I'll stop there.
Okay. Thanks for that point, Mary, or the points. And you're absolutely right. You've hit the nail on the head that training anyone to deal with this, we can't just rely on technical training. You can't just say these are the protocols you follow without addressing the values underlying them. And certainly in our work in South Africa, we included a 2-day values clarification session at the very beginning for the whole hospital staff, to get the hospital management also to reconsider their attitudes and the way they were looking at the women reporting. And it's got to be, I think we have to present it as, this is the protocol that says you do X, Y, and Z, but it has to be an integral part that you also get people to first of all look at the way that they're looking at these issues. And it goes without saying that should be done, but I can clearly see that rolling out a national protocol on, for example, both Kenya and South Africa have very clear medical management protocols, and both countries are now trying to roll those out as fast as they can. But just handing them out without the putting it in the bigger picture runs a big problem of secondary victimization and just coming up with a very technical service that doesn't meet the needs and could threaten the well-being of the woman. So the same point also goes for if the first point of contact is either the healthcare or the police, you then have, and it's probably even more of a situation in the police setting if someone's going to the police stations. And this is what these programs, certainly in Zambia and South Africa, are trying to do. The victim support training programs and such like are trying to reorientate the attitudes of police officers as well, to be supportive and to not automatically assume that the woman is out to create a problem for them. So I think regardless of whether it's the health worker or the police, that first point of contact has to be beyond just the technical, these are the procedures you follow. So absolutely. Then on your point about the research issues, I think we do have to look at effectiveness, because at the moment we've got a flourishing of different approaches. But for anyone involved in trying to sort of guide the way large-scale programs are going to go in a country, then you've got to start basing that on what works and what doesn't work. It might feel good to have these big one-stop centres, but they can only reach a certain part of the population. Alternatively, to try to integrate these approaches within the health workforce and the police workforce is a mammoth undertaking. You've got to basically work with every health worker in the country, every police officer in the country. And so, somewhere along the line, we do have to now start focusing on the nitty-gritty of cost effectiveness. What works and what does it cost compared with an alternative approach? And it's something which we do need to start pushing for. Yeah.
I'm going to piggyback on the research question because we got one from one of our web viewers. Madhumita Sarkar has a question about research. It says, there are many studies on the extent and nature of gender-based violence in camp settings, at refugee camp settings. Do we have any research on the nature and extent of gender-based violence in returnee locations? What are the basic non-negotiable interventions that must be planned in returnee locations, and how do you convince different agencies on the importance of continuing gender-based violence prevention and response efforts without data?
That is an example of a multi-part question.
Mm-hmm.
Yeah?
You get away with that when they can just start writing.
Okay, all right. So, let me give that a whirl, and you could. Okay. First of all, I would suggest that in terms of data about the prevalence and severity of the program, I would suggest that there is a significant amount out there that clearly outlines the scope and the magnitude. I mean, the World Health Organization has put out very solid studies. Other research-based organizations have put out studies. So I think that we have a good idea of the scale and scope of the problem. So when we talk about research, I like to focus it on research on the type of interventions that are going to be effective. And we have to look at a couple things. What interventions? How do we connect the work that we do in a camp-based setting? Right? How do we connect that to return programs that we know will inevitably come? Right? Eventually, refugee populations, eventually IDP populations are going to return. So how do we do our work around attitudes and belief change, service delivery, so on and so forth? How do we make sure that returns to the country of origin or place of origin? And I think that, again, anecdotally, as an organization that's been doing this for a while, we have some models and we have some cross-border approaches, but there's not a lot of work out there that shows systematically how do you do it? How do you take that journey back with them and make sure that that service delivery is appropriate there, is available there, so on and so forth. So that is something that we have to look at a lot more. And as you can see, I'm not great at remembering all parts of multi-part questions. That's why.
Are there particular strategies for framing the priority to support returnee programs when obviously it's in some ways a rhetorical question? There's a perception that there's that lack of data.
Yeah, I think, I would say let's use the data that we're seeing in Zambia, in South Africa, in stable settings. Let's use data where it's available in these countries that, before conflict hits. It's as much as we want to believe it is so, it is not logical to assume that something that existed before simply stops. Right, after conflict ends. So, I would say we use the data, the tools that we do have to reinforce the need for that.
Terrific. Yeah, we had a couple of times. Why don't we do the lady right there. And then we'll come back down this side.
My name is Leah Frage, and my question is for Meg Greene. Meg, you were mentioning that based on the Basics Report of 2006, that we need to use the opportunities for health systems to promote messages of peace, if I understood you correctly. And how would you advocate that on a practical level? I mean, how can that be carried out on a practical level, given that health systems are so overwhelmed with the work that they do? How can you propose this to take place?
The argument that is made in that report that was appealing to me is that there's the idea of a peace dividend, that there can be relatively inexpensive, high-impact public, activities that reinforce movement in a peaceful direction. I guess my point is to say that I think we saw from the presentations, we're not talking about a separate set of services under different circumstances. I think in trying to address a context of conflict and in trying to address persistent gender inequality that gets expressed in gender-based violence, we have the opportunity with health systems, with the legal system, with lots of different institutions, not to offer a different service, but to incorporate an understanding or reflection on it's basically how the services are delivered that can really reinforce that the idea of the peace dividend or a more harmonious vision of relationships between men and women and so on. It's not that it's a separate set of activities. It's the nature of the communication, the kinds of skills that might be transmitted, the openness to talking to male partners or female partners, community involvement, et cetera, et cetera. So.
Okay. We had a couple down here. Why don't we start with Deanna and then get to the other rooms?
Thanks for your excellent presentations. I wanted to get a little bit more, and your thoughts in particular, around this issue of the continuum. Really thinking about, I think you've highlighted a lot of the similarities that exist in terms of the challenges or potential response in each type of context. So I'm wondering what sort of programmatically, practically, even in terms of funding, what are some of the key issues that you think would need to be addressed to really think about that kind of continuum in two different ways? Ian mentioned Uganda, and one of the things that I think we've seen is, for example, even when geographically two different types of programming can be happening at the same time. So, for example, how the services in the refugee camps in Uganda might look different than those in the host communities, and what is that interaction between organizations in each? How can that be strengthened? And then in cases where more humanitarian organizations are really phasing out of a country and having development organizations come in, what does that communication look like? And again, some of the challenges around the funding. But I'd appreciate your thoughts on that.
Okay, and Deanna, tell everyone who you are.
I'm sorry. I'm Diana Prieto. I'm with USAID.
Thanks.
I think as the way you framed your question just illustrates the fact that there's not a single continuum here. There's lots of different situations. So you've got the one extreme when the entire country's been at war, as we hear from the Liberia or Sierra Leone, those sort of examples, and there you're going from presumably a setting where the services are available and have been created because of the conflict situation, and then you're moving from then you're moving into post-conflict on a national scale. And so clearly then you have to address the issues that Heidi was raising about moving from a temporary set of structures and procedures and just rolling that into what the evolving government structures or whatever that's coming through. Because in most situations there, as she points out, the whole structures are in complete disarray. But post-conflict, that's when structures can start to be created. And as we know, the president of Liberia herself has taken a strong lead on sexual violence and issues around that. But that compares with, that differs from a situation as in East Africa, where you've either got localized conflicts or you've got displaced people across borders and such like. And then I guess the issue then is the longevity of the camps. I mean, some of those camps in Uganda and Kenya have been around for a decade or more, and so then you're looking at the situation of, do we need to establish sort of mini systems within those camps because the people aren't able to access the general the services in the general population. So I think it's a little too context specific to come up with generalizations, but I mean that's my take. But maybe Heidi, coming at it from a different angle, you might have another way of looking at it.
Well, I mean that's a good question, and it's a difficult question, and hopefully this panel is a part of a longer term discussion. And a couple things. I think that one of the first things that we have to do to bring to help address the continuum is for violence against women and girls to be seen as a development issue. Right? That if women and girls are not going to be safe and secure in their homes, in their communities, in the schools, that is going to impact the development of a country. And so I think that that's one of the things. I think that organizationally, the emergency organizations need to, at the design really, and this is really challenging, right? It really to look at, how do we go from individual service delivery to a systems-based approach that is going to allow programs to be taken to scale. And I don't have a simple answer to that, but I think that that's how we need to look at it, because to date, there's a lot of great programs out there that are being piloted and have shown effectiveness, but not necessarily to scale. So we have to look at how that happens, and I think that that donors also need to have a discussion among themselves about how do they support that that bringing together of the humanitarian organizations and the more development oriented, because I think it's interesting thinking to my time in the field, when I would be like, okay, but there's still such a big problem, right? And my supervisor was saying, well, the emergency's over. We can't really, this is a good program, there's a big need, we can't find donors that are really interested in continuing with this long term. And that does go back to folks seeing violence against women and girls as a development issue.
That's terrific. Why don't we, because we're running out of time, capture this one down here and one in the back. We'll take those final and then give people a chance to respond. So why don't we go here first and then we'll go to the back.
This is Melanie Teff from Refugees International. In fact, you've really addressed a lot of the questions I was going to raise, which is about that relief to development gap when donor agencies often move very abruptly from emergency aid to development aid. And I wanted to ask about what impact you've seen on GBV services from when there is that abrupt shift, when there hasn't been the development agencies in place in the country and ministers of health haven't yet built up.
Mm-hmm. Okay, and then Leon, if we could go all the way to the very back. Okay.
Sue Summers, Wilson Center. Apologies if perhaps this was addressed because I came in a bit at the end. But it is a development problem, but it's also very much a law enforcement problem. And I'm interested to know when there is an effort to try to get some action by the enforcement structures in a country, what has been the role of the organizations, either the NGOs or IGOs, in that by perhaps becoming partisan, they compromise their ability to have access to the affected community, and yet what is viewed as the obligation to continue to harp or make law enforcement take some effort if it's blown off as a cultural norm or something like that. It's not a minor problem, and I'm interested to know how you approach it on a policy level.
Okay, I think we've got at least the ones who had their hands up. So why don't you guys can make some concluding remarks, and then unfortunately we'll have to close.
Okay. Well, I mean, in terms of impact on services, it's interesting because we're having a discussion with Liberia. Liberia, Sierra Leone we've been there probably in Sierra Leone since '99, and in Liberia doing GBV work since 2001. And clearly the emergency donors are receding, and we were fortunate enough as an organization to receive a large private donation, probably one of the largest donations, I think, to do GBV work that IRC certainly has ever had. So that's allowed us to move forward with, it's a 5-year, $15 million grant. So that has allowed us to move forward with, significant systems support and programming. Now, while we're fortunate, other agencies have not been so fortunate, and there's one NGO that's programming in Lofa County, and their funding's going to end, I think, at the end of June. And we're in discussions with them because that means that the Safe House closes down. That means that one of the local NGOs that they've been supporting, that to provide legal support is going to end. So I think I think we see, when that happens, we see an immediate impact on services. And on the one hand, folks say, well, then you shouldn't plan these programs, right? If they're not sustainable. On the other hand, we got 30 women a day coming to us saying, this is happening to us, can you help us? So, I mean, in terms of that continuum not being addressed, there's a significant impact, both in terms of a woman's health, the trust that was built with the community, expectations, so on and so forth. In terms of the law enforcement, I think that the work with the law enforcement, it's interesting because when you said, is it viewed as being partisan? I mean, my first thought is, remembering in Sierra Leone when we did all this training with the police force on working with survivors, and afterwards they said, well, can you give us some pens and paper, for our typewriter, right? So, I mean, we're talking like organizational support, resource support, as well as the technical support, and I guess, in the settings that we've been able to work with, using a public health approach, right, and looking at the impact of on the community, the health of a community, when police don't hold perpetrators accountable or respond, we've been able to manage the perception of being partisan. The problem comes in when it's the chief of police, that's doing the abusing, and we're, it's our advocates on the ground that are saying he can't get away with that.
I think what we're seeing in the development context is the organizationally is the challenge of, as I was mentioning before, of trying to get some focus and to bring coordination to the setup, because, as I say, in most situations, the police force are already, that's their job, is to prosecute cases of assault. And so that's been there for time, since the police force was created, basically. So it's part and parcel of what they're supposed to do. And community-based prevention awareness efforts have been going on for some time now, given the people's realization that this is needed. But then trying to put it all together and then bring in a strengthened health component is a real challenge, because it involves so many stakeholders, each of which have their own budgets, their own plans, their own way of organizing. And just trying to sort of get them to work together or see the relevance of working together is such a challenge. I mean, even within the health system itself, is it the reproductive health division's responsibility, because we're dealing primarily with reproductive health outcomes? Or, as is often the case because of the funding, is it the HIV department's responsibility, because there's a lot of funding there for post-exposure prophylaxis, and that's coming through from the donors? Or is it the social work department? Who in the Ministry of Health takes the lead on this? Or is it, for example, the Ministry of Gender? Should they be the coordinating body here, because it's gender-based violence? And so it's a real challenge from an organizational structure, and the governments are still struggling to work out there's now paying attention to this in the general populations, but how to take it forward is it's a country-specific issue because each country has its own ministry setups and so on. For generalizing and trying to make this a generally available type of integrated services, there's huge challenges there within the different sectors, and then getting them to work together, which may be because in an emergency setting that's all happening together. Maybe it's a little easier to organise, but it's, as we're hearing, it's short term. Then the challenge is are the models that are evolving there, can they be moved out? Can they be replicated? Can those ways of working together in that setting become the model of working together in the more general public? Can they in the general systems? So it is a difficult one to grapple with, and it's a difficult one also, I think, for donors to work out. I mean, you don't get, unless you've got a private donor that's going to give you substantial amounts of money, and you being an organization that may sort of facilitate that working together. But if it's going to be within the government, then one of the government ministries has to take the lead. The government allocations, the donor allocations have to be channeled through that ministry. They then have to work with the other ministries. It's not straightforward at all, and it's there for us to work out how best to work with each country on a different basis. I'm afraid. One quick thing on the I guess an unhappily positive outcome in Kenya, and I'm sure we'll see it in South Africa soon too. The post-election violence in Kenya has really invigorated efforts to try to strengthen sexual violence services in Kenya in the mainstream services. I mean, there's been such high levels of sexual violence recorded in there that, again, as Heidi's saying, that's there all the time, but it's been elevated and focused on because of the particular violent situation there. And one of the outcomes of that has been a reinvigoration and a continued strengthening in the public sectors of those services, because the violence is in the general. It's not happening in camps. It's happening in whole districts, in whole areas, and so people are having to try to look for services that aren't really there. And so it's the government is now being held to account for why aren't there post-rape services apart from a couple of NGO hospitals which are well known. And so it's helping to stimulate a change in perspective within the country.
I don't really like having the last word, despite being the eldest child in my family, because I defer to the other speakers. But I did want to just step back for a moment and contextualize the conversation and make a connection with the Interagency Gender Working Group that played an important role in organizing this event, and also plays an important role in sort of creating fora like this for discussion and pushing the debate around certain issues. My sense, after hearing the presentations and all of the comments and so on, is that there's a relief to development gap, but it's structural and institutional more than conceptual or content oriented, and that there's an opportunity maybe to do some educating of donors by making the case about the connection, about the close content connections between working in relief settings and development settings, and then encouraging kind of a broader perspective that looks at potential investments that are longer term and that have to do with the underlying social change, which I think that gender inequality is there. It's being expressed in situations of conflict and peacetime situations. That's kind of the theme song in some respects of all of this work, and there's some important education to be done around that.
Great. Well, Ian, Heidi, Meg, thank you very much, and thanks for some really terrifically good questions from the audience. I think we have kind of taken a step in trying to find ways to bridge this divide between relief and development by understanding a lot of commonalities. And I think this final point about some of the real institutional challenges may be where we need to spend some time and focus. So thank you all very much, and won't you join me in thanking our speakers for today's session.